So we're starting our session. The next presentation is very important. This is about calcified lesions, especially treating calcified bifurcation or lesions. And one of the experts in this field, Dr. Ferenc, is waiting, and he'll be. We'll have him online. Hello, Marek, can you hear me?
And again, thank you for the invitation to be faculty of this very important meeting. I hope next year I will be in place. Yeah, indeed, the treatment of calcified lesions is extremely complex issue. And what we know now, yes, our population is aging much faster than we personally believe. We see now every day much more really very complex calcified lesions. And the more calcium, the more problems can occur during PCI, because wall compliance is definitely reduced. The stent expansion is very difficult to achieve. You need much more pressure. And of course, you can achieve dissection and even ruptures of vessels. So long-term follow-up is associated with suboptimal clinical results. We know from all the data Gary Means could demonstrate very nicely. If we just take a look due to angiography, we definitely under-recognized the calcium, which can be seen in imaging IVUS nowadays with OCT. And this is picture from Dr. Collet. So nowadays, we have even option to take a look pre-angio with photon count CT, and you see the resolution here with photon count CT is excellent, comparable with IVUS. So you can then ahead make a correct planning of the procedure. You can decide, okay, we can go ahead here with IVL, we can go here with scoring, we can go here with atherectomy devices forward. Yeah, you can definitely see nearly every plaque and can easily plan upfront the strategy. So definitely, whatever we take, large data can definitely demonstrate. If we have severely calcified lesions, we have more problems during clinical follow-up. There are many different algorithms how to approach. The last one is from European Heart Journal. This is maybe more suitable to understand how to approach, and we have, of course, few options to manage calcified lesions. And this issue is coming as a fundamental, most important topic in the cath lab. So what can we use? We can use NC balloons, cutting, scoring balloons. We can go with a laser, but not everybody has a laser capability. We have laser in our center. I'm using maybe 2-3 times a year. Such device, rotation atherectomy system there must be a tool in every cath lab nowadays. Of course, the same topic is a shockwave balloon, and orbital atherectomy, also very useful device to prepare lesion. And this is for younger doctors. This slide is for younger doctors, just to understand the anatomy. In case if you have ring calcification, so you can maybe go inside with some wire, maybe with a small balloon, a low-profile balloon, but you will be not able to crack this calcium. So you have to use some device to ablate to make this ring thinner. Then you can crack during follow-up this wall and go with stenting ahead. So which which devices we have? Our rotablator is easy nowadays in easy going, but there are some limitation per mostly a tortuous vessel. This is you should take this into account. If you have very tortuous vessel, you can go through, you can have a burr stuck, and then you will be not able to remove the burr back. What I could already test by Boston Scientific, there is now in the pipeline olive burr, which is covered by diamond surface completely. So you can go forward and you can even ablate if you go backwards. This is different at the moment to the orbital atherectomy. You see there is a metal conus, and in the middle of this metal conus there is crown. This crown is rotating, making a kind of elliptical movement. So you have crack possibility, and you have sending of the plaque. There's only one size, 1.25 crown. And there are still some colleagues who believe there is all these devices maybe not really needed. However, I can show you the data from two large German randomized studies, and whatever you do, you will find in around 20% of calcified lesions which are definitely not suitable for balloons. So you have on top go to ablative methods. So this is for sure. I think even in more complex lesions, maybe it will be 20-30% the case. Left main lesion are nowadays usually in older patients, so they are either very old or they use for many years statins. So the plaques are very hard, and you should know how is the plaque distribution in the left main. Usually, in 90% of cases, plaque is coming from left main to LAD, and in nearly 70% from left main to LCX. So this is exactly important to know this. If you have imaging upfront, you can then make a right choice with double stenting, or if possible, you can use provisional. And this is a case which was moderate calcified. So you can go here with one stent from left main to intermediate branch or marginal branch, one more stent, and then kissing with circ and kissing with a drug-coated balloon to the LAD. So you can manage such lesion very elegant with just one stent. But you have this is now an example for 80 years old patient with acute coronary syndrome, and what to do. It's a subtotal left main. You see that it's extremely tough case. And if you go ahead now with PCI, surgery guys usually don't like to have such patients on the table. So you go with rotablator, just make a channel, then a balloon, then stent left main to LAD. You prolong one more stent to LAD. And what you can recognize here, there is a balloon in position to the circ. So as is a jail balloon technique, I do this sometimes in such complex anatomy. So if you have flow to the circ, which was not perfect, then actually you can wire the circ much easier. And then finally, the result was here not really perfect. So finally, you have to go ahead and to do, in this case, step. Very useful method is here to use stent boost or clear stent, so you can see extremely well position of the side branch. So finally, you can manage such a case with ablative methods very nicely, and you can just see in different case this very bulky plug in distal left main. I wanted actually to go with rotablator. This was my initial plan, but finally The problem is if you go with orbital atherectomy or rotablator, you have just one wire in position. And if you go by IVL, which was really possible in this case, you have side protection. So you have two wires in position. So you have prodilate, make a channel of around 1.5 millimeter. Then you can go with 3.5 shockwave. And finally, you can manage this very, very calcified lesion by culotte. It was Dickey culotte stenting. So with all these modalities, you can manage this very nicely. What is really very important, if you have such very calcified distal left main, you see this is nearly trifurcation, and you have ejection fraction of 18. Yeah, that's something what you can manage very nicely only if you have protection, hemodynamic protection support with Impella CP. So what we have done, we rotablate to LAD. We could not wire initially to the circ. Then after that, we wired circ, do it kissing just to have flow and to stabilize the patient. And then finally we stented here, it was Megatron stent, very, very stent with very good radial forces and dedicated for calcified lesions and left main. So finally we could go here with triple kissing and showing here, and a drug-coated balloon for the proximal LAD. I cannot show you the IVUS, but we have done IVUS. So both ostia to marginal and to LAD were nicely open. So we didn't put stent. So this is an example. You can manage such difficult anatomy just with one stent. What I want to show you with orbital atherectomy, there is a metal conus, and crown is in the middle here. There is a distance of around 6-7 millimeters. And sometimes you are not able to reach bring the crown to the proximal cap. This is different here in rotablator, but this is a limitation. So I have done now around 160 such cases. It was not possible to bring the device down in 7 cases from 160 cases. So, but if you have very tortuous anatomy, calcified lesions, so this orbital atherectomy is very helpful. There's practically no risk to have burst duct, and yeah, you can manage such tortuous lesions with orbital postdilatation with NC balloon stenting and postdilatation very nicely. This is something for shockwave, rotor shockwave. Just make a channel for shockwave, and then you can finally manage such patients with method which is known rotor shockwave, very, very elegant. Yeah, shockwave is very useful. You see, you can not only postulate or prodilate with shockwave unexpanded stents, but this was the first case. I believe this strategy, this method is really working nicely, so I could manage this in-stent restenosis only with shockwave. And we do a lot of rotablator cases in our center. We publish now data of around 820 patients, and we compare it planned versus bailout rotablator use. And to my surprise, there was no difference for planned rotablator use. I believe this will be the way, but finally, don't forget some complications like slow flow or burst duct can still happen and make us a big problem. So we now go only in selective cases, primary with rotablator. Try to go with a balloon. If balloon is working, fine. Then we go with IVL. If balloon doesn't expand or doesn't cross, then of course the first choice will be rotablator. And we have also data showing here from randomized studies there is no sufficient significant clinical benefit if you use a priori rotablator. Eclipse study, just one comment, comparison orbital atherectomy with standard NC balloon PCI. Large study from US, 2,000 patients. Yeah, you see strategy success of around 80%. Is not perfect. Complications rate, yeah, more perforations in orbital atherectomy study arm. And finally, there was no significant benefit according the primary imaging endpoint in OCT cohort. And clinical data, you see after 1 year, was also not beneficial. But don't forget, this is pre-selected patient subset. Normally, we definitely need all these devices in our daily cath lab. And orbital atherectomy, yeah, you can very elegant manage even such difficult anatomy. You can send this plug and finally use one stent method and provisional approach for side branches. One more final remark. Roll-Costa EPIC 22 trial, they compared rotablator, IVL, and laser. And you see there was very interesting data. Even if you go with a priori with primary with some device strategy, still you need in around 10% of cases to switch to one more technology which is needed to achieve final result. In this study, the IVL was non-inferior to rotablator use. And we have also Victory study published in TCT, comparison OPN balloon. Probably everybody in your centers has this balloon available. It was comparison IVL versus IVL versus OPN balloon, and you see there was no inferiority for OPN. So OPN and IVL are at the similar way according to the study data, and it was comparison also cutting balloon with IVL, again similar level of results. So both study didn't had third arm NC balloons, standard NC balloons with maybe 20, 22, 24 atmospheres. So I show this. I have to go forward. Sorry. Just go forward. Yeah, very important topic is imaging. And you see, October study had in around 20% left mains. And October study could demonstrate a benefit if you perform guided treatment of bifurcation lesions. iLumen 4 study, again, a benefit by trend for OCT guidance. If you go to Renovate complex PCI, again, highly significant benefit for imaging guided PCI. So there is something what we should take into account. However, there is some more analysis after 5 years, just analysis of 5-year mortality, CABG versus PCI in left main, and you see there was no significant difference anymore. Why? Because if such PCIs are performed from in hands of experienced operators, probably there is maybe this will be associated with better clinical results. However, the latest analysis could show mortality in CABG versus PCI with or without final IVUS. And you see now we have a data from randomized study after 10 years. I think the data is really very interesting because it's not showing if you use during PCI IVUS after 10 years, you are better than cabbage and definitely better than PCI without imaging. So this is probably the way how we can make the PCI in such complex anatomy in the future for sure. Then we will be comparable with our colleagues from surgery department. So there is now at least a signal that we can do even better than surgery guys. Interestingly, PCI in acute coronary syndrome patients, PCI was associated with lower mortality compared to cabbage. So that's why usually we send such patients to the cath lab and not to surgery guys. If you don't cross with balloon or micro, you have to go with rota or laser. And this is something what you should take with you. If you don't open balloon, then IVL, rota, or orbital or laser will be optional. And for some special lesions, when we cross the lesion with wire, I think this Javelin IVL catheter will be very useful in the future. There is emitter here in proximal part, and you can go ahead and give shockwave forward, so you can probably manage a big part of uncrossable lesions with this device. 5 French comparable, and this console is like standard by shockwave. So this device will be available on the market must, as I know, maybe at the end of this year. And we will be make a channel, and this will be a huge progress in setting how to manage calcified coronary lesions. So dear colleagues, rotablator use, orbital atherectomy, shockwave, laser performed definitely safe in and experienced hands, are associated with a high procedural success rate. All devices can be and should be combined according to the availability in the cath labs. IVL, OPN, cutting balloon show it in randomized studies similar outcomes, but it was just to show all these devices are really effective. And as I showed you a few slides from imaging, IVUS and OCT play a very important role during PCI to plan and to optimize the final result. Thank you so much.
Marek, it is Valery. Can you hear me?
Yes, I can hear you.
Thank you very much once again from my side for your contribution extreme to this event. And I have one question, and it is pity you are not here, but hopefully next year we will rely on you. Do you have your own approach to something in calcified lesion, because we have a different patterns of calcification, and how do you address calcified nodules? This is something that I think is unresolved, and we don't have data on this.
Yeah, that's correct. What we saw, if you go with OPN balloon in calcified nodules, there is definitely a higher risk to perforate the vessel. So we don't do this. We usually go with IVL balloon. And this is usually working. If I go then a next step with NC balloon, and I see NC balloon doesn't open really, there's only practically one option to manage such case. What I'm doing, what I'm using is IVL, sorry, not IVL, orbital atherectomy on top. And you can, I don't know, can you hear me now?
We can hear you very well.
Yeah. Yeah. Then with orbital atherectomy, you can make some due to elliptical movement, and if you go with 120,000 rotations, and then you can ablate, send the calcium much more effective, and then you can check this by imaging again. And usually it's working. So this is, yeah, of course, you have to be very careful with stenting, but I think this is the only option at the moment how you can do this. As some people say, okay, laser will be is effective, but you need this device, you need also some learn curve. But this will be maybe in the future device which we will use much more frequently.
Thanks.
But again, I think the point is to go with NC balloon. Balloon doesn't open. If there's really subtotal lesion, then a rotablator. If the vessel is tertius, I'm going with orbital. Then usually on top IVL, and then confirmation in imaging. If the plaque is prepared well, then you can go with a stent implantation.
Because in some cases, as a mechanism of this early restenosis, this is again a protrusion of calcium through the struts of the stents, and this is something that is very how to say, unpredictable in some cases.
That's correct. Even in some cases we still go with OPN on top. This makes only a few % of such patients, but we still do this, but very gently.
Thanks. Any other questions?
Mirek, one question from my side. It's Dobrin.
Yeah.
What do you think will be the advantage of this double ablating burr, which we are waiting for maybe more than a decade, but maybe it will appear this year or next one? The burr which is capable to ablate to and fro and back. This is, you thought that you already had.
That's a very good question, Dobrin. If you go forward, you can go maybe more to lateral wall. If you go backwards, maybe you will be able to ablate the plaque from the inner wall. This probably it was my experience in bench testing. I use it. I tested this device already. So it was a bit more predictable to ablate from all sides from inner vessel. For me, my impression was it is much more effective. So this will be, I think, a huge improvement for us.
So
but
that means
don't forget the burr stack at the moment is some issue. And it's a really very, very tough complication.
As a comment, probably this will change the philosophy and will, in a way, solve the wire bias, because when you go forward, the direction of the wire is in one direction, and if you have the ability to rotablate going backwards, it goes to the other side of the vessel, and probably this could be
exactly.
We will see, just because actually this is the burr stack. I think that this is mainly problem of training of the operator from some cases which I saw, but mainly this is an issue regarding the competition from orbital atherectomy, and this is another alternative if there is a burr which is capable just to make an ablation front and back. This is just a comment.
I personally believe this. We had 1 week back calcified meeting in Wrocław in Poland with live cases, and there was also session with complications. So what we saw, practically all burst ducts cases which were demonstrated happen with 1.25 burr. So that's why in our cath lab at the moment, this is really only exception to use 1.25.
Yes.
We usually start with 1.5. This makes around 80% of cases, and 15% on top we go with 1.75, sometimes 2.0. It's, but 80% is 1.5, and we try to avoid 1.25.
Yeah, this is a very good and clear message, because people are using, I saw in the past, many use 125, which is not safe. I personally started to do that in the past, but in the last years, maybe more than 6 or 7, I'm personally doing more than 90% of my rotablations with 1.5.
It's a matter of technique, really, because the main issue of burst duct is because the burst stops to rotate. And if it stops to rotate, it doesn't matter whether you have diamonds on the front or on the back of the burst. So you should do it slowly, and you should have patience just to overcome, make some space, wait, and that's what I think.
What I personally saw, it is because of the operator was too fast.
Yeah, exactly. Patience.
Yeah.
Yes,
Patience is very important.
Patience, yes.
Yeah.
Patience.
Definitely.
Number one,
And
don't rush.
yeah, and we go with a higher speed. We start with 175,000 and escalate after a few runs to 190, 200. This is usually very effective and safe.
And what's the rationale to increase the to escalate up to this, let's say, from 170 to 190?
What I can tell you, I can cross safer the lesion. I can. We have much less situation where you feel okay if you just go forward. You have a burst duct. So this is much less since I'm working with
just to prevent burst duct. And there is some issues with temperature, which is also important. I mean, injury of the tissue. So, thank you, Marek.
It is, but you don't. Yeah, we do now maybe 5 seconds one run, not like many years back, 15, 20 seconds. You know. This is something which is not.
That's very important. I mean, in fact, you reduce the length of the one push.
Yes.
Okay, it's to 5 seconds, because
and
usually it is recommended 15 or something. So you reduce it. That's an important, how to say, tip and trick.
Short time, a lot of repetitions.
Any questions? Comments?
Eva? I see you're impatient to ask something.
No, I have just one. Hello, Professor Ferenc. Thank you for sharing your experience. But I would like to ask, do you have any experience for using guiding extension in a setting of bifurcation lesions and rotablation to separate ablation of the both branches?
I had, it's a very good question. I had one complication with rotablator in diagonal branch. I couldn't cross with nothing, so finally I rotablate, but it was perforation. And finally, I managed this case, but I overstented the ostium of the diagonal branch with a covered stent. Then I had a similar case. Then I used orbital atherectomy to go to the side branch. And again, no slow flow, no flow, dissection. Finally, I lose this vessel. This is really very sporadic, but you cannot be sure you can manage this 100% safe. And nowadays I'm trying to go. Then I had 1 or 2 cases with laser. This is effective technology, but again, slow flow can occur. I think in 3 cases, 1 case was with severe slow flow with some stress, but finally you can manage this if you have a lot of patients. So the cases, if you have 7 French and you are not able to bring a stent to the side branch, what is very helpful, you can go with a balloon, and then over balloon you can bring guideline 5 French into the ostium of the side branch, and then you are able to bring a 2.5 some low profile stent like Synergy or Zero or something like this, and then you can manage this double stenting. In some cases this is the only option.
More questions, comments? If no, thank you once again, Mirek. Thank you.
Yeah, thank you, and hope to come
Thank
next
you,
year.
Mirek. We'll
Thank you,
wait for
dear
you next
friends.
year.
Yeah,
Have a nice day.
and Dobrin, I have to say, I was in your center in last year, and we had really very tough cases to manage in 2 days. And Dobrin showed me to use drug-coated balloon for 2 minutes. Dobrin, we use it now, this approach in our center with a very, very good experience level. So thank you for sharing this strategy with us.
Yes, it's good
way.
that it is accepted in Germany, but not in Bulgaria.
But you increase the rate of peri-procedural myocardial infarction.
No, there is no problem. Okay, Mirek, thanks.
Thanks.
Yeah, thank you so much. Wish you a nice day. Bye.